Hello dear learners, my name is Muna Jones. Today we are discussing history taking in mental health. The history taking is one of the important diagnostic tools a psychiatrist has to obtain information to make an accurate diagnosis. Although these important tools have been standardized in their own right, they remain primarily subjective measures that begin the moment the patient enters the office. The clinician must pay close attention to the patient's presentation, including personal appearance, social interaction with office staff and others in the waiting area. These first few observations can provide important information about the patient that may not otherwise be revealed through interviewing or one-on-one conversation. When patients enter the office, pay close attention to their personal grooming. One should always note things as obvious as hygiene, but, on a deeper level, also note things such as whether the patient is dressed appropriately according to the season. For example, note whether the patient has come to the clinic in the summer with 3 layers of clothing and a jacket. These types of observations are important and may offer insight into the patient's illness. Other behaviors to note may include patients talking to themselves in the waiting area or perhaps pacing outside the office door. Record all observations. Legally, a mental status, if conducted against a patient's will, is considered assault with battery. Therefore, it is important to secure the patient's permission or to document that a mental status is being done without the patient's approval if in an emergency situation. The time it takes to complete the initial interview may vary. However, with experience, interviewers develop their own comfortable pace and should not feel rushed to complete the interview in any time that is less than comfortable for either the interviewer or the patient. All patients require their own time during this initial interview and should never be made to feel they are being timed. The next step for the interviewer is to establish adequate rapport with the patient by introducing himself or herself. Speak directly to the patient during this introduction and pay attention to whether the patient is maintaining eye contact. Mental notes such as these may aid in guiding the interview later. If patients appear uneasy as they enter the office, attempt to ease the situation by offering small talk or even a cup of water. Many people feel more at ease if they can have something in their hands. This reflects an image of genuine concern to patients and may make the interview process much more relaxing for them. Beginning with open-ended questions is desirable in order to put the patient further at ease and to observe the patient's stream of thought, content, and thought process. Begin with questions such as "What brings you here today?" or "Tell me about yourself." These types of questions elicit responses that provide the basis of the interview. Keep in mind throughout the interview to look for nonverbal cues from patients. As they speak, for example, note if they are avoiding eye contact, acting nervous, playing with their hair, or tapping their foot repeatedly. In addition to the patient's responses to questions, all of these observations should be noted during the interview process. As the interview progresses, more specific or close-ended questions can be asked in order to obtain specific information needed to complete the interview. For example, if the patient is reporting feelings of depression but only states "I'm just depressed," determining both the duration and frequency of these depressive episodes is important. Ask leading questions such as "How long have you had these feelings?" or "When did these feelings begin?" and "How often do you feel this way?" or "How many days in the past week have you felt this way?" These types of questions help patients understand what information is needed from them. For safety reasons, both the patient and the interviewer should have access to the door in case of an emergency during the interview process. At some point during the initial interview, a detailed patient history should be taken. Every component of the patient history is crucial to the treatment and care of the patient it identifies. The patient history should begin with identifying patient data and the patient's chief complaint or reason for coming to the clinic. The patient's chief complaint should be a quote recorded just as it was spoken, in quotation marks, in the patient's record. This also is where all history of illness is recorded, including psychiatric history, medical history, surgical history, and medications and allergies. Of interest, it is important to make direct inquiry to items such as family history of members being murdered. Patients often do not volunteer this information. Additionally, listing any family history of illness is important. This information can be very useful later when determining treatment options. If a family member has a history of the same illness and had a successful drug regimen, that regimen may prove to be a viable option for the current patient. If possible, record the medications and dosages family members took for their illnesses. If these medications and dosages worked for family members, the chance is good that they may work for the current patient. Obtain a complete social history. This addition to the patient history can be most crucial when discharge planning begins. Inquire if the patient has a home. Also ask if the patient has a family and, if so, if the patient maintains contact with them. This also is the area in which any history of drug and alcohol abuse, legal problems, and history of abuse should be recorded. It also includes any information that may aid the physician or other clinicians in making special accommodations for the patient when necessary. This would include an accurate record of the last grade completed in school, whether the patient was in special education classes, or if the patient required special assistance at work or school. Common investigations peculiar to psychiatry. Hematology group, hemoglobin, red blood cell indices, leukocyte count and differential, platelets. Chemistry group, electrolytes, liver function tests, glucose, calcium, renal function tests, serum. Proteins. Serum for vitamin B12 and folate. Syphilis serology. Thyroid function tests, total thyroxine and thyroid stimulating hormone. Erythrocyte sedimentation rate. Urinalysis. Other blood tests include HIV antibody screen. Drug levels of psychopharmacologic agents. Drug levels of agents of abuse. Autoantibody screen and immunoglobulin, IgGs. Cultures for infectious agents. Urine. Urine drug abuse survey. Urine screen for drugs or toxic agents. 24-hour urine levels for lead, mercury, arsenic, and other heavy metals. Imaging. Computer tomography or magnetic resonance imaging of head. Cerebral angiography. Immunoglobulins, cultures. Neuropsychologic testing. If alcoholism is suspected, add blood alcohol level. Superscript 3 glutamyltransferase. Triglycerides. For nutritionally depleted patients, consider zinc, copper, carotene, iron, or serum transferrin levels. Triiodothyronine. Total serum protein, albumin globulin ratio. Basal metabolic rate. Mental status examination. Appearance. Record the patient's sex, age, race, and ethnic background. Document the patient's nutritional status by observing the patient's current body weight and appearance. Remember, recording the exact time and date of this interview is important, especially since the mental status can change over time, such as in delirium. Attitude toward the examiner. Next, record the patient's facial expressions and attitude toward the examiner. Note whether the patient appeared interested during the interview, or, perhaps, if the patient appeared bored. Record whether the patient is hostile and defensive or friendly and cooperative. Note whether the patient seems guarded and whether the patient seems relaxed with the interview process or seems uncomfortable. This part of the examination is based solely on observations made by the healthcare professional. Mood. The mood of the patient is defined as sustained emotion that the patient is experiencing. Ask questions such as "How do you feel most days?" to trigger a response. Helpful answers include those that specifically describe the patient's mood, such as depressed, anxious, good, and tired. Elicited responses that are less helpful in determining a patient's mood adequately include okay, rough, and don't know. These responses require further questioning for clarification. Establishing accurate information pertaining to the length of a particular mood, if the mood has been reactive or not, and if the mood has been stable or unstable also is helpful. Effect. A patient's effect is defined in the following terms: expansive, contagious, euthymic, normal, constricted, limited variation, blunted, minimal variation, and flat, no variation. A patient whose mood could be defined as expansive may be so cheerful and full of laughter that it is difficult to refrain from smiling while conducting the interview. A patient's effect is determined by the observations made by the interviewer during the course of the interview. Speech. Document information on all aspects of the patient's speech that will include quality, quantity, rate, and volume of speech during the interview. Paying attention to patients' responses to determine how to rate their speech is important. Some things to keep in mind during the interview are whether patients raise their voice when responding, whether the replies to questions are one-word answers or elaborative, and how fast or slow they are speaking. Thought process. Record the patient's thought process information. The process of thoughts can be described with the following terms: looseness of association, irrelevance, flight of ideas, change topics, racing, rapid thoughts, tangential, departure from topic with no return, circumstantial, being vague, beating around the bush, word salad, nonsensical responses, jabberwocky, derailment, extreme irrelevance, neologism, creating new words, clanging, rhyming words, punning, talking in riddles, thought blocking, speech is halted, and poverty, limited content. Throughout the interview, very specific questions will be asked regarding the patient's history. Note whether the patient responds directly to the questions. For example, when asking for a date, note whether the response given is about the patient's favorite color. Document whether the patient deviates from the subject at hand and has to be guided back to the topic more than once. Take all of these things into account when documenting the patient's thought process. Thought content. To determine whether or not a patient is experiencing hallucinations, ask some of the following questions. Do you hear voices when no one else is around? Can you see things that no one else can see? Do you have other unexplained sensations such as smells, sounds, or feelings? Importantly, always ask about command-type hallucinations and inquire what the patient will do in response to these commanding hallucinations. For example, ask when the voices tell you do something, do you obey their instructions or ignore them? Types of hallucinations include auditory, hearing things, visual, seeing things, gustatory, tasting things, tactile, feeling sensations, and olfactory, smelling things. To determine if a patient is having delusions, ask some of the following questions. Do you have any thoughts that other people think are strange? Do you have any special powers or abilities? Does the television or radio give you special messages? Types of delusions include grandiose, delusions of grandeur, religious, delusions of special status with God, persecution, belief that someone wants to cause them harm, erotomanic, belief that someone famous is in love with them, jealousy, belief that everyone wants what they have, thought insertion, belief that someone is putting ideas or thoughts into their mind, and ideas of reference, belief that everything refers to them. Insight. Assess the patient's understanding of the illness. To assess patients' insight to their illness, the interviewer may ask patients if they need help or if they believe their feelings or conditions are normal. Judgment. Estimate the patient's judgment based on the history or on an imaginary scenario. To elicit responses that evaluate a patient's judgment adequately, ask the following question. What would you do if you smelled smoke in a crowded theater? Good response is call 991 or get help. Poor response is do nothing or light a cigarette. Impulsivity. Estimate the degree of the patient's impulse control. Ask the patient about doing things without thinking or planning. Ask about hobbies such as playing football, pool among others. Reliability. Estimate the patient's reliability. Determine if the patient seems reliable, unreliable, or if it is difficult to determine. This determination requires collateral information of an accurate assessment, diagnosis, and treatment. The following physical examinations are peculiar to psychiatry. Observation. Knowledge of a patient's weight is extremely important. It is obviously vital in anorexia nervosa, but it also helps to confirm the extent of weight loss due to neglect in a patient with psychosis and of weight variation in depression. Furthermore, a weight chart provides an important indicator of weight gain due to psychotropic drugs or dietary intake during admission. Cardiovascular examination. Hypotension is seen in anorexia nervosa and Addison's disease. Postural hypotension is seen in autonomic dysfunction associated with diabetes mellitus and Lewy body dementia, as well as being an unwanted side effect of chlorpromazine and tricyclic antidepressant treatment. Anemia is suggested by pallor of palmar creases, and subconjunctiva may be seen in patients with a history of chronic self-neglect and poor dietary iron or folate intake due to illnesses such as depression, schizophrenia, and anorexia nervosa. Complexion, a feature rarely mentioned in mental health texts, is often altered in depression when it may appear sallow and gray. Palpation. A handshake is not only a mark of courtesy but also a potential source of information. A warm, sweaty palm may give some clues about endocrine disorders such as thyroid disease or acromegaly. A fine tremor helps to add weight to a clinical diagnosis of thyrotoxicosis, whereas cold tremulous hands are seen in anxiety disorders. Tremor may be caused by medications such as lithium and neuroleptics. A symmetrical coarse tremor associated with the latter, together with bradykinesia and rigidity, suggest iatrogenic Parkinsonism. Asymmetric signs, in the absence of medication, point to primary Parkinson's disease, which is commonly associated with depressive disorder. Neurological examination. The principal objective of a neurological examination is localization. Speech is another important baseline assessment, as symptoms cannot be communicated readily without it. The patient should be asked to do the following: you stand with feet together. You close eyes. You open eyes and walk heel to toe in a straight line forwards and backwards. You walk on tiptoes and then on heels. You hold their arms outstretched with palms facing upwards. You hold this position for a few seconds. You, with eyes closed, touch the nose with the tip of the index finger that the examiner has just lightly touched. Then touch the nose with the tip of the middle finger that the examiner has just lightly touched. You pretend to play the piano with the arms still outstretched. You pat the back of each hand with the opposite palm. You, while facing the examiner, screw eyes tight. You give a grin. You protrude the tongue. You wiggle the tongue. You stare at the examiner's face and, as the examiner wiggles one finger in each outer quadrant on the left, then on the right, and then wiggles one finger on the left and right at the same time, the patient should point to the moving fingers. You follow the examiner's finger, with head still. The finger should move across the midline to shoulder width on either side and then move up and down. This procedure should be repeated on the opposite side. You sit on the examining couch while the examiner tests the patient's reflexes. You allow the examiner to examine the fundus with an ophthalmoscope. Gastrointestinal system. Examination of the abdomen should always be carried out with the patient lying flat. Abdominal examination is important when alcohol misuse is suspected. Summary of findings. Here will be an anomaly, that is, if truly patient is mentally sick, and findings under mental status examination like appearance, attitude towards the examiner, mood, affect, speech, thought process, thought content, judgment, and impulsivity reliability. Laboratory findings will also reveal irregularities in that respect. History taking will also depict something to confirm diagnosis. Psychiatric diagnosis. The diagnosis is done according to DSM-IVTR standard, which uses a multi-axial classification scheme consisting of five axes highlighted below, and each of which should be covered in the diagnosis. Axis I consist of clinical disorders like mood disorders, schizophrenia, generalized anxiety disorder, and other disorders that may be of importance in this respect. Axis 2 is divided into clusters, namely Cluster A with paranoid, schizoid, schizotypal, Cluster B consisting antisocial, borderline, histrionic, narcissistic, Cluster C with conditions like avoidant, dependent, and obsessive-compulsive personality disorder, mental retardation. Axis 3 general medical conditions like epilepsy, cardiovascular. Axis IV psychosocial and environmental problems, for instance injury, divorce, death of a loved one, and all other conditions relevant to the illness. Axis V global assessment of functioning as shown by the patient during the interview, for example social, occupational, and psychological function. To achieve this, a rating scale with a continuum from 100, which represents superior function, to 1, which represents grossly impaired functioning. Strengths, resources, and weakness, problems identified during assessment. Strengths. The presence of the DSM-IVTR standard to help in diagnosis is a strength. Human resource presence, as in multidisciplinary team, to help in the total care can be another strength. Presence of patients' relatives to help in history taking is also resourceful. Government support in terms of policy formulation and infrastructure development for the mentally ill is another. Financial support to institutions that take care of the mentally sick can be strength too. Weakness. Insufficient funding to these institutions can be a problem. Uncooperative patient poses a challenge. Lack of laboratory facilities is another problem. Long stipulated time to confirm diagnosis of a psychiatric patient can be a challenge. Shortage qualified staff to a thorough assessment can be another challenge. Thanks for watching this video. Kindly share and click subscribe button for more educative content.